Is your practice tired of wrestling with insurance denials, deciphering EOBs, and watching your revenue slip through the cracks? You are not alone. Welcome to The Claim Game, the podcast designed to cut through the confusion and provide you with the best practices for revenue cycle management success. We are Jeremy and Kathryn Zug, and we've been with people just like you in the trenches. Each week, we'll break down complex billing processes, share real-world solutions from practices like yours, and ask questions of the game makers and changers of healthcare so you can take control of your revenue. Let's turn those claim denials into deposits and help you return to focusing on patient care. It's time to win the claim game.
Hello, welcome back to The Claim Game. You'll notice I'm in a different location. I'm currently at a conference in Madison, Wisconsin, and we're going to record the intro for our guest. Occasionally on the Claim Game podcast, we take a moment to interview the game makers and game changers of healthcare. These are the people that influence healthcare in ways that we may or may not notice or observe. And today we have the absolute pleasure of interviewing Jill Steeley. Our guest today, she is a powerhouse in the world of community health. She is someone who understands the high stakes reality of the FQHC model. And as the former CEO of PureView Health Center, Jill didn't just keep the doors open, she transformed the organization's DNA. When Jill took the helm of PureView, the center was facing nearly a $1 million deficit, and through a relentless focus on operational excellence and culture, Jill led a turnaround that resulted in $5 million in cash reserves while simultaneously doubling the patient count and growing revenue fivefold. But she'll be the first to tell you that the numbers are only half the story. She talks about lives that were changed when the health center is finally on solid ground. Today, she's taking those hard-won lessons to a national stage as an executive coach, KPI trainer, and host of the Community Health Collective podcast. She spends her days helping FQHC leaders move past survival mode to navigate the impossible balance between mission and margin. Please welcome Jill Steeley. Well, tell us a little bit about your background. How did you know you wanted to get involved in FQHC work, and round out your background a little bit?
I fell into it accidentally. So when I did move to Montana, to Virginia City, that's actually the county seat for Madison County. And I didn't know what I was going to do. I was working at Goldman Sachs in Salt Lake. Yeah. And when I got to Virginia City, I went to the county commissioners and said, do you have anything that I can do? This is my skill set, because we really had moved there for my husband's career in historic preservation. So I really didn't know what I could do there. It was in the early 2000s when there were a lot of anthrax attacks going on. And so there was a lot of money from the federal government being pumped into local and state government to respond to bioterrorism attacks. And so when I went to the county commissioners, they said, well, we have this bioterrorism grant that we're about to lose because we haven't done anything with it. So if you can get us caught up on that, we'll pay you to do that. But one of the deliverables, most of the deliverables required them to have a public health department, and they didn't have one. So started one for them. That required me to do a road trip around Montana, see what the other county health departments looked like, and then come back and start ours and, implement public health services that hadn't existed in the past in that county. From there, I got recruited to move to Bozeman, which is a bigger town in Montana. And I got recruited to run the human services division of their county health department.
Wow.
And then I actually started graduate school to get my master's in public health when I was there, because I found that I did have such a passion in public health, and it really met two of my passions, and brought them together, which is business and helping people. So I started grad school at the University of Montana. And shortly after I started that program, I got recruited to Helena, Montana to run the federally qualified health center here. So I did that for many years. So I really just fell into it accidentally.
You did sort of back your way into that center as a career.
Yeah, but it is definitely what I am meant to be doing. And I love it.
So you get to the FQHC and it was kind of a mess, right?
Yeah, it was a big mess.
Yeah. So describe what you show up day one. Were you like bright-eyed and bushy-tailed, or were you knew this was a little bit of a journey?
So when the recruiter called, I had friends in my public health ecosystem who ran other community health centers. So I knew the CEO of the community health center in Bozeman, and I knew the one of the health center in Billings. And so the recruiter called me and I called them to see what they thought. And they
Nice.
Well, you might want to Google the health center because they've had quite a few problems. And so I did. And it was just a bunch of headlines about staff being laid off, staff going to the media about how bad it was there.
No.
Just all kinds of problems. And I remember my mom, who was a business owner, I called her and I said, "What do you think?" And she said, "Well, it can only get better. Well, it's not because of something you did. It was already on its way." So I decided to go ahead and give it a shot. I had some proven success in fixing or starting businesses essentially in my past. And so I thought, well, I'm going to go ahead and do it. What I walked into was a health center that had almost $1 million deficit that was growing very quickly every day. They hadn't recruited a medical doctor in 5 years. They had not been able to recruit a medical doctor. They hadn't been able to recruit a dentist, so their dental clinic had closed down. And their patient numbers were declining every year. We had a terrible payer mix. We were, about 42% uninsured and, I think like 12 or 13% Medicaid. And then, it just got worse from there.
Oh, no. So you started at a $1 million deficit and then ended with millions of dollars in reserves. So that's just the KPI, but the day by day of how you transformed that organization. I mean, I know you can't recount like day by day what happened, but can you take us through the big milestones of transformation there? Like, what do you do with that? What did you do with that to get them to millions of dollars in reserve?
Sure. Yeah, it's something that I teach now. Now I am a consultant for other FQHCs. So I definitely teach these strategies. The first thing I knew I had to do, first of all, my mindset and my ideology has always been you have to run public health or community health like a business. Public health specifically is part of a local government structure. And so we tend to run it like that, where we're really dependent on grants and we're really dependent on the county's infrastructure and the county's funding to keep that department afloat. And my health center was a county department when I started there. We were a public entity health center, which is a fairly rare model for FQHCs. But at the time, we were part of the county government structure. And so it really had not been run like a business. It had been run like a county department that was just surviving grant cycle to grant cycle. And the county, if I'm being honest, wanted to keep it that way. They did not want us to be successful. They thought if we serve the poor, we should be poor too. So that relatable and people can feel like they're in the right place when they come to it. So my first order of business was to think about, what would a profitable business do if they were in this situation? Well, the first thing they would do is figure out how to get more customers through the door. So I went on my crusade for 12 months was to get in front of as many people as I could in our community to tell them about our health center, to tell them what the services were, to tell them that we saw everyone, even if you had insurance, because that was the big misconception in our community. And it is with most FQHCs, is people think, well, I have insurance, or I'm not low income, or all these different things, so I can't go there. And that's why they don't come. So
Yeah.
I was able to get large employers to partner with us and make us their preferred primary care provider for the people on their health insurance plans, so their employees, their spouses, their dependents. And that really brought in a lot of privately insured patients because they were insured by their employer. And then we launched a huge rebrand and marketing campaign, and that helped us attract a lot of people as well. And then I spoke in public however I possibly could every single week, almost the entire time I was the CEO, but it was most critical for those first 12 months. Just I'd go speak in civic groups or to churches or to other nonprofits or people's staff meetings. Sometimes there'd be 3 people there. Sometimes there would be 30 people there. I didn't care. My goal was to just tell them who we were, what we did, and who we served.
Wow.
That.
Yeah, that's amazing. I'm going to jump around a little bit, but so you do this now as a consultant. You have this like 5-step approach, right, for how to turn this stuff around. Can you walk us through that? I mean, don't give away the keys of the kingdom too much, but can you walk us through the 5-step approach and how you work with FQHC teams to do this?
Yeah. So when I started my business, I met a guy named Steve Weinman, who had also for years held pretty much every executive level position at a health center and had been a consultant to health centers for about 12 years. And I really quickly realized that we shared that same philosophy, that you have to run it like a business, a profitable business, in order for it to be sustainable, keep the doors open, and to be able to serve the underserved. Because so many people will say, well, we're not supposed to make a profit. We're a nonprofit, or we're a safety net provider. If we're trying to attract privately insured patients, then we're not in alignment with our mission. And to me, I always say, no margin, no mission. You can't serve those underserved patients if your doors are closed. To attract people with a payer and serve people with a payer in order to serve the people without a payer. So we started together, we started a CEO boot camp it is for FQHC executives, but we've had executives from rural health clinics, tribal health clinics, small critical access hospitals, because the principles are the same. The business principles are the same, whether you're running a community health center, a rural health clinic, a tribal clinic, whatever it is. And what we teach them in that boot camp is, first, diversify and increase your revenue. And we give them all kinds of strategies to do that, including what I was just talking about with getting contracts signed with large employers, self-funded groups, and then getting out in their communities and doing these presentations at least once a week in their communities, doing actual marketing to people with a payer. And I'll get into that in just a minute. So the first module of our CEO Bootcamp is all about increasing and diversifying revenue, because you've got to stabilize before you can grow, right? The second thing we teach them is how to reduce costs. So as we know, the cost of healthcare is the most expensive probably in this country than anything else. And for community health centers, it's even more expensive because they are having to provide medical, dental, behavioral health, to people who don't have a payer, right? So we have to figure out, we don't want to increase revenue and not look at our costs, because then we're not really doing anything. So we teach them those big revenue leaks that they have that they probably don't realize they have. And then we teach them how to fix those leaks. Let me give you a couple of examples. So a huge cost to health centers is the no-shows. No-shows in general cost the healthcare industry $150 billion a year. And so when you think about health centers that are serving, Medicaid patients, let's just use them for an example. If you have a 20% no-show rate, which is fairly common, especially in behavioral health, so you have 20% of those appointments being no-showed, you're now paying providers to not do anything, right? You are making it so that those appointments are not accessible to other patients. You are also losing the cost of the visit. So if you have a $200 reimbursement rate and 20% of your 10,000 Medicaid visits are going no-show, that is a huge cost to the health center. So that's one thing that we focus on. We help them fix that rate. We give them lots of tools and resources to do that. Another big cost is staffing. There's turnover costs, which are 50 to 250% of a person's salary. So that's hundreds of thousands of dollars. If you have a provider leave, that's a couple $100,000 at least that it's costing you for that turnover. So we want to fix that. We've got to fix the workforce challenges that have been so prominent since COVID. It's really affecting community health centers. So we give them a lot. We have a whole mini course on how they can recruit and retain high quality staff, because that is a huge revenue leak right there, just their turnover rate. We also look at optimizing the staffing schedules, because so many times when health centers are in financial trouble, they start to cut, and they will cut staff first. But the problem there is now they're understaffed. So now they can't see as many patients. So then they're not making as much money on, seeing patients. And it's just like this snowball that's rolling down the hill, collecting more and more snow and costing them more and more money to not have optimized staffing levels, not have optimized patient schedules, and just losing hundreds of thousands of dollars, if not millions of dollars, just with that problem right there.
Wow. Unbelievable.
Yeah. The third thing that we teach them is marketing and branding, because like I was saying, so many times, and this was certainly true for my health center and why we rebranded, was we had a terrible reputation in the community. Remember all the headlines?
Right.
And when we surveyed the community to do our rebrand, only 23% recognized our brand. And 84% of those people, that 23%, thought we were the county health department and we only did travel vaccination.
Oh my gosh. It's like not even close to what you wanted.
Right. So we launched our rebrand. We saturated the market with our new name and what we did. We spent a lot of money. Remember, we were in a big deficit at the time. I knew we could not afford to not do it. So many health centers that I work with tell me, oh, we don't advertise. We don't do any marketing. We don't need to. We're here for the underserved. Again, it's that mindset. So we launched this huge marketing campaign, and we surveyed again a few months later. And this time it was like 67% recognized our new brand. And almost all of them knew what we did and that we took all insurances.
Oh, let's go.
Got everyone.
Yeah.
a year later, or actually 2 years later, we were at 96% brand recognition. Almost every single one of them knew what we did, who we served, and said that they either are using the health center or would use the health center.
Wow, amazing.
So it was absolutely amazing. I recommend everyone do it. And we teach that in the boot camp, how to have a presence in your community. Take a huge marketing budget. There are things you can do to put your health center on the map and be top of mind when people are, because it's not like you and I are thinking, boy, I might need a doctor's appointment 6 months from now. When we need a doctor's appointment, we need a doctor's appointment.
Yeah, that's right.
And what do? We Google it, or we think about what was that last commercial that we saw, or what's that jingle that's in our head all the time.
Yeah.
And we call that place. We start there. So you want to be that place that people think about when they're ready to make an appointment.
Oh, that's amazing. Yeah.
I think that was 3. The 4th thing we teach is this exceptional patient experience.
Okay.
And consumers expect something very different now after the pandemic. And patients are really looking for transformational healthcare and not transactional healthcare. So that requires us to really think about their experience from that very first touch point, which is probably them scheduling an appointment, to being seen at the appointment. And then what does our follow-up communication look like with that patient? So it's an entire experience. It's not just they come in for their appointment, we never talk to them again unless they come back. So, it's so much cheaper to retain a patient than it is to try to attract new patients. If you have a high turnover rate of patients or a low retention rate of patients, that's really costing a health center a lot of money. Not to mention the fact that they probably aren't recommending you. If they're not coming back, they're probably not leaving you ratings and reviews. So we really want to make that experience exceptional for them so that they do become your super fan, so that they do use your health center more than that one time. And they use your other services, and they use your pharmacy, and they tell other people about it, and they leave you a great rating or a great review. So we teach them how to do all of that and improve their patient outcomes, because people have to come in order for their outcomes to improve, their clinical outcomes. So that's all in the 4th thing that we teach, which is that exceptional patient experience. And then the 5th thing we teach is just how to keep that momentum going and long-term planning. So not losing momentum, not taking their foot off the gas and saying, well, we pulled on one of those revenue levers and that's working. Now we can just coast until the next funding cycle, right? We want them to be less grant dependent, more financially sustainable. And so we teach them how to do that in the long term.
Jill, that's amazing. I mean, it makes me want to sign up, honestly. That sounds really great. This episode is brought to you by Jane, a practice management software and EMR built to support you in the day-to-day work of running your practice. If you're a health or wellness practitioner, you already know the care you provide starts well before your client arrives and extends far beyond the treatment room. Jane is there to support you in every part of that experience. With online booking, your clients can book at a time that works for them. And with features like notifications, they'll even be able to grab last-minute openings when they pop up. It's an easy way to keep your schedule full while getting your clients the care they need. During your appointment, Jane's AI-powered documentation feature can help you thoughtfully take notes so you can stay present with the person in front of you. And after appointments, you can end your time together on a healing note, not a transactional one, by charging the card on file. To learn more about how Jane can support you and your clients, head to jane.app/demo. And one last thing, if you're ready to get started with Jane, you can use my code in the show notes for a 1-month grace period on your new account. Can we shift gears to talking about the grant-only mindset and payer mixture?
Absolutely.
So I've noticed this in interacting with a lot of agency owners in the market, and it does feel like grant cycle to grant cycle, it's like we're hanging on by our fingertips and just kind of hoping that it builds. How do you shift either a brand or a leadership team to attract private insurance patients without losing their core mission of serving the underserved? And how do you get them to look at payer mixture critically?
That's a great question. I actually am doing a webinar on that this Friday and next Friday, because what we see is, so there was just some funding that was approved for health centers, and it goes to the end of the calendar year. And it is more than we've seen in the past, so it's great. But what most health centers will do is either bail themselves out, use that money to kind of bail themselves out of a bad situation that they are already in because they've been in survival mode for years, and not think of what investments they can make with that money now so that they are not in this position again, so that they can become less dependent on the federal funding. Because it got approved this time, but lately it's always a fight. It is always a fight to get that funding approved. And we just don't know, what does that look like in 2027 and 2028? It may not be there at all. So you really have to figure out how to be a sustainable business. The health center program and the 330 grants were not meant to build strong businesses. They were meant to provide more access to people. We, as the leaders of those organizations, have to figure out how to make them strong businesses without that funding. So what I always, and that's what I talk about in my webinar on Friday and next Friday, is that mindset shift that has to happen. We have to think about, what do we need to do right now with this funding so that we're never in this position again, that we're never thinking about what's going to happen with the next grant cycle. For me, that's investing in yourself as a leader, learning new things, learning the business skills that it takes to build a stable and sustainable business. It requires you to make technology investments. There is amazing technology these days for healthcare. So often, health centers will not invest in technology. They expect their staff to work from, the laptop that weighs 25 pounds and slow as molasses, because they think it looks bad to spend money on new technology. But the problem with that mindset is those people will go somewhere else that does have the new technology. You expect your cell phone to work at lightning speeds every day, all day long. And if it doesn't, you're frustrated. They're frustrated too. They're frustrated with their slow Wi-Fi, with their clunky software programs, or with, software that doesn't talk to each other. So it's a lot of duplicate entry, manual entry. We don't need that anymore.
No.
There are so many great vendor solutions out there that can use AI for billing, for coding, for claims recovery, for scheduling appointments, for reminder calls, for all the administrative functions that people are doing in health centers. It can save a health center so much money. I mean, they get their ROI on those kind of things within months, right? Not years.
Well, for sure. Yeah.
And when people can work faster, when providers have AI scribes instead of them doing their own scribe work, then they can see more patients. And they're happy to see more patients. So many times we get this pushback from them, but that's because they're so slow at it. Because their technology doesn't work right. And then they're staying late and still charting and all the things. So technology investments, just investments in general that are going to make your staff more knowledgeable. Professional growth is high on the list of priorities for people now. We all saw this huge shift in the workforce after the pandemic. It's been a lot harder to recruit people Professional growth has been in the top 2 recruiting strategies for the last 5 years. Why is that? Because people want to go work somewhere that values their growth. And so many times we put a lot of money into our providers and their professional growth, right? We pay for their continuing education, but that's for their license. That is for them to learn technical skills. But what are they interested in outside of that clinical care that might benefit their patients or might benefit them as a provider at your health center? What does your front desk staff want? What do they need to look like they are growing as a professional, that they're not just in this dead end job that's, paying them by the hour, and they're dealing with unhappy people, and they have to de-escalate people, and they have to use hospitality skills. So can we get them some training in that? Investing in your entire staff's professional growth is another big investment to make while you have some extra funding.
No, it's amazing. Yeah, I mean, I think that's incredible. And I think one of the things that we've noticed from the FQHC world or the community mental health world is that clinicians, providers, they burn out and then they go start a private practice and they realize that the grass might even be greener over there because of the private insurance payer mixture thing. What could FQHCs do to attract more of those private insurance folks and find a way to blend up the revenue in a way that can provide some of the benefits of a private practice model while still serving the underserved?
Yeah, again, I think health centers are in a really good position to attract Medicare patients. A lot of private practice will put a cap on how many Medicare patients they will see, or those providers, they retire. And so that population of people are looking for a new provider, and they're looking for somewhere that will take Medicare. And that's a great payer for a health center because of the PPS rate that health centers get. So I think trying to look like a private practice, and again, that's one of the reasons we rebranded, was so we looked like private practice to people. Our name was Cooperative Health Center. That sounds like government healthcare, right? Rebranded to PureView Health Center. I can't tell you how many clients I have or how many health centers that have run through the CEO boot camp that have a name that sounds like government
health center. Yeah.
Or it excludes certain groups of people that would be private paying or have a commercial payer, like having the word God in your health center title or name excludes everyone who doesn't have a faith or doesn't have a organized religion, right? It's very off-putting to them. If you have a health center name that is specific to one religion, like Christian, or one population base, like a Hispanic name, but you also want to attract, other populations, other cultures in your community, you really have to think about, is your name exclusive? Does it make people feel like they can't go there because they don't belong to that group? So there's just lots of things that we can do, lots of tweaks we can make to look like private practice and attract the patients that are going to private practice so that we can change that payer mix for our health centers. So we can keep the doors open and we can keep seeing the people that don't have a payer.
Yeah, that's fascinating. Yeah, talking about AI, I mean, you've written about this a lot, I think. Now, if you were running an FQHC right now in an AI age, which is what a lot of folks are doing, what would you be doing with AI? How would you be thinking about AI? Yeah,
you're right. I've done a couple of podcasts about this because I see it as it's scary. And what I hear a lot of my clients say is, I don't think we're there yet. I don't think we should be using AI yet. It's not going away. And it gave you a lot of money It can literally replace positions in your health centers. So some interesting conversations I've had recently are using AI for billing and coding, like we talked about a little earlier, using it for AI scribes that then also do the coding or suggest the codes to the provider. So many health center providers will undercode because they just aren't quite sure how to code. We don't do a great job of keeping them up to date on that, keeping them trained on the correct coding. And so if you were able to dictate your notes and have it put them in there for you, so it's listening only during the visit, only for the things that are important for the note, right? Which is amazing to me.
It's incredible.
Yeah. And then it's putting those in the notes, and then it's saying to the provider, we think you should code this as a 3, or this should be a 4. Do you approve? So they still have to use their judgment there, but it's at least suggesting based on the chart notes what it should be coded as. Then all the provider has to do is review that chart note and say, yes, go ahead and lock the chart and code it that way.
Yeah, it's one of the best advents of our time with AI is ambient scribing. It's absolutely incredible.
You know, and I know a lot of people say, well, it takes just as much time for me to review it. Or maybe they're like, I'm a perfectionist, and so I go in and I make a bunch of changes to it. So I might as well have just typed it myself.
Wow.
But I think that's just a limiting mindset that we have to get over. I'm the same way. I'm a perfectionist. I like things to be very accurate, and I'm very detail oriented. But I use AI all the time to help me brainstorm, to help me think, to help me look at information differently. And I've just gotten used to scanning it and reviewing it. And that's just what you have to do. And you have to trust in the technology. So definitely invest in the right solution. And that's what I do for my clients is I vet different solutions to make sure they are the right fit. Yeah. And then I would use AI, for scheduling, for bill pay, or chat bots. I never call companies customer service anymore. If they have a chat bot, I'm chatting with them. I do not. And most people don't want to get on the phone. And we pay people to play phone tag with patients or insurance companies. And you can use AI agents to make those calls to insurance companies for prior approval, for work through a claim that's been denied. It's shocking how much we can eliminate from our task list by using AI in an appropriate and compliant way.
No, you're totally right. I saw a demo by a guy named Uriah Guilford who has an AI receptionist. And it was amazing. I mean, we were throwing really complicated names, Jill, at the AI receptionist, and it was spelling them correctly. And 9 p.m. calls and getting them on the schedule, and a human being can review all the calls and stuff. But why wouldn't you want one of those answering the phone on a Saturday at 6 p.m.?
Yeah, totally. And I just did a podcast with Athellis, and they use AI agents to call insurance companies. And I thought, but what happens if it's not something that can be resolved by an AI agent? And she said, oh, it'll transfer the call to a human if it can't, if it's not getting anywhere. We're not taking the humans completely out of it, and we shouldn't. We should not do that. And I'm not suggesting that we go fire half our staff. Replace them with AI. But what I am saying is if someone leaves a position and they've been doing a lot of manual administrative tasks, or their job was to sit on the phone and make these phone calls, then try using AI and not replacing that position and seeing your ROI on that very quickly, rather than, sitting on that recruitment hamster wheel, trying to find people to do these tasks that technology can do.
Yeah, obsolete tasks, not people. So that makes all the sense in the world. Yeah, I hope the adoption rate among health centers goes up, because I think they'd be very happy with the tools that are being developed for sure. So I imagine you talk a lot about measuring outcomes in a business. I mean, you had the metrics for your health center off the top of your head. Are there any metrics or KPIs that healthcare leaders track that you think is a total waste of time?
Gosh, that's a great question. What usually happens with the health centers, so they have some requirements from HRSA, the Health Resources and Services Administration. And a lot of times they will only track the measures that HRSA is requiring them to track. And they're only doing it once a year when it gets time to submit their annual report to HRSA, that they are looking at those measures. So that right there is a giant waste of data, in my opinion. First of all, we have to know, where do we want to go in the next 1 to 3 years? If our health center was going to be a center of excellence in the next 3 years, where do we need to improve our health center operations, our patient outcomes, our patient experience, our, whatever it is? And then I would figure out what needs to be tracked as far as data goes every single month to know that we are getting there. And we only look at data once a year because we're required to, basically looking in the rear view mirror, and there's nothing we can do about it. So it's not so much that I think people are measuring things that are not important. It's that they have the information. I always say in healthcare, we're so lucky because we have so much data at our fingertips. You look at other nonprofits, they don't know who's coming back. They don't know. They don't know a lot of the things that we know. They don't know the demographics. They don't know how to target them to get them to come back, all the different things. So we're very lucky. And if we're not using that data and we're not tracking it consistently throughout the year, there's really nothing we can do with it. If you're starting to see your patient numbers declining, or that you are not retaining patients, there are things you can do about that right now to get that fixed, rather than 12 months from now going, oh gosh, we lost a lot of patients last year and we didn't even realize it. So to me, it's, where do you want to go? What do you need to track to know you are getting there? And then tracking it, being very intentional about that.
Yeah, you need some of those leading indicators to tell you what the music is going to do in 3 months, so that you know how to adjust. Yeah, it's so important. All right, so crystal ball us a little bit here, Jill. In 2027, what's the biggest challenge you think is coming for community health centers?
I think there are some big changes to Medicaid eligibility that are going to really impact people, health centers, Medicaid populations. I think there is going to be a lot of fighting for funding again. We not get it this time because they'll say, well, we just gave you a bunch and now we have other priorities. I think the rural health transformation funding could be really great for the health centers that are eligible for it. And there's more information coming out about it, and they haven't released it yet. I mean, it's been approved, and I think it's been sent to the states. But as far as like eligibility and all of that, that's still coming. And I'm going to put together like a packet around applying for those funds for people. But I think that that people, again, are looking for transformational healthcare. If they know you exist, they will come to your health center They're going to love it because FQHCs are the best. Services they provide are amazing. And the people that work there are salt of the earth people. But if they don't know you exist, they're not coming. So I just think there's a lot of opportunity to get in front of people. A lot of people are really tired of that transactional healthcare that they're getting somewhere else. So be front and center, get in front of them, have them pick you, and then just dazzle them while they're there so they keep coming back. That's what I see coming in 2027. I am not so much doom and gloom. I'm more like, how can we act now in order to be in an amazing position in 2027 and beyond?
Yeah, that's a really good piece of feedback. I'm not doom and gloom either. I mean, you're going to go through Medicaid changes every administration. And so I love the worldview grid that you have around positioning the health center in a way that is resilient to change and diversified enough that you can take a couple hits and keep going, because I think in the grant cycle mentality, you're going to get stuck somewhere.
Yeah, I mean, I've got clients that, they're losing sleep because every discussion about funding feels like a direct threat to their health. So we've got to figure out how to get out of that dependency and to have revenue streams that we control, that, if we pull on one and we focus on it, it'll increase and get better. We don't have that kind of control over grants and federal funding.
Yeah, that's right. Yeah, you have to control what you can control. Well, if people need more Jill in their life, where do they go? How do they get a hold of you?
Well, I'm on LinkedIn. I think it's Jill Marie Steeley on there. I'm at jillsteeley.com, and they can always email me too, jill@jillsteeley.com. I also have my own podcast, which is called the Community Health Collective.
Amazing. Well, Jill, I really appreciate you being here. It's incredible feedback, and anyone who's done what you've done has a lot to share. Again, thank you so much for coming on and talking with us.
Thank you for having me. It's been fun.
All right. Until next time, for sure.
If you enjoyed today's episode of The Claim Game, please take a moment to leave us a rating and review wherever you listen to your podcasts. It really helps new listeners to find us. Make sure you never miss an episode by subscribing to The Claim Game on your favorite podcast app. Your feedback means so much to us. We want to provide valuable education about revenue cycle management. So if there's something we didn't cover in our topic that was a burning question for you, please let us know so we can try to get you the information you desire. You can find the links to all resources we mentioned in this episode in the show notes. And if you want to dive deeper into our resources, we have two places you can do that. First, you can go to our blog at practicesol.com/blog, where we have 8 years of educational blogs. If you want to learn more about what Practice Solutions does, reach out. We'd love to hear from you. Just go to practicesol.com to learn more and to connect with one of our awesome people on our team. Thanks for listening. We are Jeremy and Kathryn Zug, and this is The Claim Game. See you at the game table next time.